away.
Yeah.
Yes.
Thank you.
So the first presentation.
Should I share my screen?
Would be on by Rucha Bang on OVD. So judges, kindly note, we will be putting on the judges WhatsApp group. The timing will be on the right side of the screen. So Rucha, you can start. Your time starts now.
Technical help, please
Yes,
make
sir.
sure the timer is on.
Yeah. Please start.
Good afternoon. I'll be presenting on. Hello. Hi. Yes. Good afternoon. Myself, Dr. Rucha Bang, and we'll be learning ophthalmic viscosurgical devices today under following headings. Starting with introduction, OVD is a class of non-active surgical implant that are clear gel-like chemical compound with viscous and elastic properties. Term was coined by ISO, International Standards Organization, and first viscoelastic use was sodium hyaluronate. Now, what is need of OVD in our surgeries? For protection of endothelium, for maintaining anterior chamber depth, ease for capsulorhexis, it improves visibility, and for IOL implantation. Now, properties. Four major properties are pseudoplasticity, viscosity, coatability, and elasticity. Pseudoplasticity is ability of change of viscosity at differential rate. Our ideal OVD should be optically clear, inert, isotonic to aqueous humor, not interfere in wound healing, and should have sharp absorbing properties. Coming to composition, three major components. First is HPMC, hydroxypropyl methyl cellulose. It occurs naturally in plants and not found in animal or human body. It is main component of dispersive agent. Sodium hyaluronate. It is a glycosaminoglycan with a good space maintaining property. Coming to chondroitin sulfate, it is also a GAC present in cornea and coats the endothelia. Coming to classification of OVDs, based on the parameters of zero shear viscosity and cohesion dispersion index, it is classified into four broad categories of cohesive, dispersive, viscoadaptives, and combined agents. Coming to spectrum of OVDs, what are dispersives? They are short chain molecules with low viscosity and low molecular weight. They provide better coating and protection to the endothelium. Whereas cohesive, they are long chain molecules with high viscosity and they tend to maintain the space. Now we can see here properties of dispersive and cohesive agents. Dispersive OVDs are OcuCoat, Viscot, and Helon coat. Now we can see in this video, which is playing, for dispersive, we see that we inject a dispersive agent going across the anterior chamber, and while coming out, it coats the endothelium. Whereas for cohesive, we can see when we enter, the cohesive agent tends to be in the space and stretches the capsule. Now coming to viscoadaptives, as the name suggests, at low flow rate, it maintains AC, and at high flow rate, it coats the endothelia. Whereas higher viscosity dispersive OVDs, they have intermediate to high viscosity. Coming to uses, almost all ophthalmic surgeries make use of OVDs, like cataract surgeries, glaucoma, posterior segment, keratoplasties, globe injuries. Coming to new recent advances of viscoanesthesia when it is used with lidocaine and viscostaining of the capsule where it is used with tryptan blue dye. Now coming to some techniques of use of OVDs. Soft shell technique. In this, first we inject a dispersive OVD, which is indicated in yellow color, and beneath it and posteriorly, we inject the cohesive OVDs, so that a dispersive moves upward and coats the endothelium and cohesive maintains the space. Tri-shell technique, we also use balanced salt solution. Now, how to remove OVD? We have rock and roll technique, bimanual irrigation aspiration, and compartment technique. We need to remember cohesive OVDs are easier to remove than the dispersive ones. Complications, we have secondary glaucoma, post-op IOP spike, capsular block syndrome, IOL crystallization, corneal edema decompensation. Coming to practical aspect and application of OVDs on day-to-day life. Like for a patient with endothelial dystrophy, dense cataract, we make use of dispersive OVDs to protect endothelium. For small pupils, non-dilating pupil, and intraoperative floppy iris syndrome, we use cohesive OVDs that tend to dilate the pupil, called as viscomydriasis. Thank you and happy Independence Day.
I think you can ask a question if you deem necessary. Rucha has finished her presentation. You can start.
Rucha, yeah, it's a good presentation. So, can you tell me about indication of cohesive OVDs? Few common
OVDs we
indications.
can use in sir in shallow temples or
Clinical indications,
hello
particularly
sir in case
clinical.
of sir in glaucoma surgeries we can use
Okay, what else?
glaucoma surgeries while providing while doing trabeculectomy. Uh, uh,
Particularly in which types of the cataract? Okay.
Okay, judges. So I think our 1 minute of questions is up. So you can start marking in the next 30 seconds on our judges group, please. Till we change over, I think in the meanwhile, Sakshi Patel can be ready with congenital ptosis. Sakshi, are you ready with your presentation?
so just a minute, we'll be sharing a slide.
Yeah. Okay, Dr. Mangesh is ready with his marks. On our central TOT
Hello?
judges group, yes, Girish Gadre sir is ready with his marks. Yeah, in the meanwhile, you can start Sakshi for congenital ptosis.
Yeah.
So judges,
Yes,
kindly
sir, just
note, this is the second participant from TNMC. This is the second of the group with Rucha. So she'll be presenting on congenital ptosis. This is Dr. Sakshi.
Good afternoon. I'm Dr. Sakshi Patel. I'll be presenting on congenital ptosis. Congenital ptosis is the drooping of the upper eyelid since birth or within the first year of life. The pathophysiology basically here is that the LPS fibers are replaced by adipose tissue and fibrous tissue, leading to loss of elasticity and inability to retract or contract or relax. Etiology is simple congenital ptosis and complicated congenital ptosis, wherein it's associated with superior rectus muscle weakness, blepharophimosis syndrome, Marcus-Gunn jaw winking. Other less common causes are third cranial nerve palsy, Horner syndrome, secondary to birth trauma, and periorbital tumors. Complicated ptosis accompanied by other conditions, for example, BPES, which is blepharophimosis, ptosis, epicanthus inversus syndrome. It is an autosomal dominant condition associated with FOX1 gene mutation. Marcus-Gunn jaw winking phenomenon, where the misdirected mandibular branch of cranial nerve 5 is supplying the pterygoid muscle. On retraction of the ptotic lid is seen on stimulation of the ipsilateral pterygoid muscle, which is elicited by chewing, sucking, and mouth opening. The third one is double elevator palsy, which is associated with superior rectus muscle palsy. History of presenting illness. Some of the symptoms seen in such patients are visible drooping of one or both eyelids, diminution of vision, head posture abnormality, and diplopia and upgaze. The last one is usually associated with SR palsy. In these patients, we have to ask for history of birth trauma like forceps delivery and family history as well. Objectives on seeing a patient of ptosis is to identify etiology, evaluation, and outlining various management options. For evaluation, the first thing we do is inspection, where we see the head posture, facial symmetry, chin elevation. Various measurements to be taken are palpebral fissure height, the margin reflex distance 1 and 2, margin crease distance, LPS function by Burke's method as seen on the right side image. Absence of crease in congenital ptosis indicates poor levator function. Ptosis can be graded based on the difference of MRD1 of both eyes in unilateral cases or difference from normal in bilateral cases. The first one is mild, which is 2 mm, moderate 3 mm, and severe is more than 4 mm. Treatment options are, first we see the prerequisites where we check for lag of thalamus, corneal sensation, astigmatism, cosmesis. Timing of the surgery, if there is no risk of amblyopia and the patient is comfortable, we can wait till they're of 3 years of age so that we can do a better assessment of the patient. If amblyopia has set in, we can do the surgery urgently. The surgery depends on the levator function, where the amount of upper lid excursion is seen and the LPS action is assessed. 15 mm of excursion means the LPS action is good. 8 to 15, excellent, sorry. 8 to 15 is good, 5 to 8 is fair, and less than 4 mm is poor. Types of surgery. For mild ptosis with good LPS action, we can do Fasanella Sorvat procedure. Moderate ptosis with good LPS action, LPS resection, and severe ptosis with good LPS action, LPS resection. Where the fair LPS action is seen in all kinds of ptosis, we can do LPS resection, and in poor LPS action, frontalis sling is preferred. A Fasanella Sorvat is indicated for mild ptosis with good levator action, where the maximum elevation achieved is 2 to 3 mm. Levator resection can be done for both congenital as well as acquired ptosis, which is useful in moderate to severe ptosis with fair to good LPS action, has anterior and posterior approach both. Frontalis sling, two common techniques are seen, which are modified Crawford double triangle and Fox pentagon technique. Some of the commonly used methods for suspension are silicone rods, temporalis fascia, fascia lata. Thank you.
Okay. So good. I think Dr. Sakshi is finished. Judges, if you can start asking your questions for the next 1 minute, please.
Which are the muscles? Hello.
Yeah,
Yes,
please
yes,
go
Hello.
ahead.
please. Please
Yes,
go ahead,
Which
sir.
are the muscles
Yes, sir.
which will help to elevate the lead?
Okay, so there is the levator palpebral superioris, the frontalis muscle, and molar muscle.
Okay, okay.
Okay, any other questions that the judges want to ask? We have another 30 seconds of questions left.
That's okay.
Okay, thank you. Thank you, Sakshi.
Okay, yeah, thank you, sir.
So the next speaker would be Sanskriti Prasad. That is contraindication for laser refractive surgery. Sanskriti, are you there?
Yes, sir. Good afternoon, sir.
In the meanwhile, the markings will be done. You can just share your screen. I'll tell you to start when our time is done. Yeah. So Sanskriti, you are ready? Our judges are ready.
Yes, sir.
Okay. Your screen is seen. Your timer starts now.
Good afternoon, everyone. I am Dr. Sanskriti from Grand Government Medical College and Sir JJ Group of Hospitals, Mumbai, here to speak about contraindications of laser refractive surgery. First of all, I would like to thank MOS and BOA and the Teachers of Tomorrow coordinators for organizing this competition for us, and a very happy Independence Day to you all. Laser is an acronym for light amplification by systemic emission of radiation. And it can be used for various procedures, but I would stick to my topic of contraindications of laser-based refractive surgeries done for myopia, hypermetropia, presbyopia, and astigmatism. It can be excimer laser-based, femtosecond laser-based, or a combination of both. The contraindications can be ocular, systemic, or drugs. The ocular contraindications include unstable refraction, extreme refractive error, severe dry eyes, progressive corneal ectasias, and etc. In systemic contraindication, it could be pregnancy, lactation, and systemic autoimmune disease. And various drugs are also in contraindication. Unrealistic patient expectations could be another relative contraindication. Unstable refraction. That is, as we know that the refraction is unstable until the age of 18 years. So the refractive surgeries are done only after 18 years, and a stable refractive error for more than 1 year is required. That is variation of plus minus 0.5 diopter sphere in 1 year. Extremes of refractive error have been given by FDA approval, that minus 10 diopter to plus 4 diopter spherical refractive error and less than plus 4 diopter cylindrical error could be done for surface ablation and LASIK, and other than that, all are contraindicated. As we know that during flap creation and excimer laser stromal ablation, corneal denervation occurs, which is the most significant cause of post-LASIK dry eyes. Post-operatively, patient experiences symptoms of dry eyes, which may be uncomfortable for the patient or which might aggravate already existing severe dry eyes. Corneal ectasia should be evaluated using corneal topography and tomography. Excimer ablations that result in very, very thin residual stroma increase the risk for ectasia. A minimum of 280 microns has been suggested as a safe residual stromal bed thickness, but there is no absolute value since the posterior cornea exhibits weaker tensile strength than the anterior cornea. Abnormal topography is the most significant risk factor for post-operative ectasias. We can see the oculus pentacam and see the at-risk cornea status through the 4 maps. Other ocular contraindications include corneal scars, uveitis, or any other uncontrolled infection, herpetic eye disease, large pupil, uncontrolled glaucoma, or cataract. In the systemic contraindication, There is an increased risk of an excessive inflammatory reaction in the eye in autoimmune diseases, resulting in vision-threatening corneal complication such as severe dry eyes, corneal haze, corneal opacity, etc. And according to the recommendations of the FDA and AO, the well-controlled autoimmune diseases are a relative contraindication, whereas the uncontrolled one are an absolute contraindication. There is a significant increase in progesterone and estrogen levels in a woman's body, which human cornea exhibits receptors for all of these. The hormonal changes influences the eye of pregnant women, causing an increase in corneal pachymetry, weakening of corneal biomechanics, and excessive water accumulation in the cornea. The other drugs can be also a contraindication, though this is in research process right now. There have been found that the cornea exhibits certain receptors which could relatively contraindicate the uses of these drugs. And finally, the patient's unrealistic expectations is one of the most often important and ignored contraindication, as when we have a patient who is usually asking too many questions, we try to avoid refractive surgeries in those patients. We try to counsel them that the results might not be perfect, and you can get a use of glasses even after surgery, and there can be an early eventual presbyopia. And if the patient is willing not to do the surgery and they might be unhappy or unsatisfied with the result, then we usually contraindicate the refractive surgery laser based. Thank you.
Excellent. So now judges' question for the next 1 minute, please.
Very
Dr.
good presentation.
Thank you, sir.
Can you tell me the two most important investigations to rule out if there is any corneal ectasia or not?
Sir, we can do topography and tomography.
Okay.
Yes, sir. And
Any other? Yeah.
see the core chart in that.
Yeah. Is there any relation of peripheral retinal degeneration and contraindication?
Sir, retinal conditions can be a relative contraindication. Sir, for laser refractive surgeries, the peripheral retinal conditions can be a relative contraindication, and it is usually decided by the surgeon if they want to operate.
What is its relation exactly? How they are contraindicated?
Sir, the peripheral degeneration can be there in, it is usually there in the case of high myopes, and that could be a contraindication for laser refractive surgeries.
Yeah, but how LASIK will precipitate that? How refractive surgery will precipitate that peripheral degeneration, become high risk? Any mechanism?
Okay. This is the last question. Can you answer that, Sanskriti?
Sure.
You can answer that in the next few seconds. Gather yourself, no problem.
Yeah, sure.
Next 5 seconds, if you can answer that question for you. Okay, judges, you can start marking on our group. The next speaker be ready in the meanwhile. It is Dr. Sarbik Dey, who will be talking on optic disc exam in glaucoma. Sarbik has shared his screen. If judges are ready, we can start the timer.
So,
Yeah, please.
Yeah, so please mark Sanskriti Prasad first, please, before we start the next presentation on the judges TOT central group. Yes, we've got all the 3 markings. So I think Sarbik, you can go ahead with your presentation. I'll be announcing the next presenter on the TOT central group, so that be ready and gather yourself in that time. All the best. Go ahead, Sarbik.
Hello?
Yes, sir. Sarbik, please go ahead. Your timer has started.
Sarbik Dey icon display.
Sarbik Dey. Your screen is shared, but you are on mute. Your screen is shared, you are on mute. Sarbik Dey.
Yes, sir. Yes, sir. Good afternoon, everyone. I'm Dr.
Yeah, please start. Yeah.
From Grand Government Medical College and Sir JJ Group of Hospitals, Mumbai. My topic for the day is optic disc examination in glaucoma, mentored by Dr. Manoj Kumar Agarwal, sir. Why is optic disc examination important in glaucoma? 30 to 50% of patients have normal intraocular pressure at first visit. By and large, the structural changes in the disc precedes visual field defects, and it also cooperates with the visual field field defects. It can be used to detect progression of glaucoma. It is a cheap modality. And although perimetry is an important investigation in glaucoma, it has been seen that there is severe lack of access. It is expensive, it is difficult to interpret, and it is cumbersome for the patient. How to examine the optic disc? It should preferably be done with dilation. There are two modalities, direct ophthalmoscope and slit lamp examination. Direct ophthalmoscope, although gives higher magnification of 15x, but there is less stereopsis present, while in slit lamp examination, the stereopsis is good. The cup to disc ratio is widely accepted to be 0.3 to 0.4. However, the CDR should be observed in context of the disc size. A CDR asymmetry of more than 0.2 should raise suspicion of existing glaucoma. ISNT rule, it is for neuroretinal rim width. What it says is that the most thickest of the four zones will be inferior, followed by superior, then nasal, and then temporal. In glaucoma, there can be focal as well as generalized rim thinning. Although this is not obeyed by all the population, 40% have been found to only be obeying it. Why inferior and superior poles are more affected? These regions contain large number of fibers with larger poles to accommodate them, with decreased connective tissue support, making this region more susceptible to the laminar tilting as well as axonal damage with the slightest raise in the IOP. We also do RNFL examination using the red-free light. We look for striations and parapapillary retinal vessels. In the first image, we can see the striations. In the second image, we can see the RNFL wedge defect. Parapapillary atrophy occurs in two zones, alpha zone and beta zone. Beta zone is more associated with glaucomatous changes. However, it is neither sensitive nor specific, and hence it is not deemed to be significant. The disc hemorrhages are very important. They are more commonly located in the infratemporal region, more commonly seen in normotensive glaucoma, also can be seen in anglocrucial glaucoma. It is caused due to neuroretinal support loss leading to kinking of the vessels, causing hemorrhages. It indicates disease progression. Normally, the color of the neuroretinal rim is pink. However, if the color is pale, which indicates pallor, it will indicate non-glaucomatous neuropathy, more likely neuronal cause. Optic disc size is very important. It is measured with direct ophthalmoscope or slit lamp. In direct ophthalmoscope, we use 5-degree small aperture. In slit lamp, we use correction factor as per the lenses used. If the size is deemed to be small, if average vertical diameter is less than 1.4 millimeter, it is determined to be large. If it is more than 2 millimeter, larger disc, the CDR may be falsely overestimated. In smaller disc, the disc may miss out the changes due to the changes are not seen due to overcrowding of the vessels. In vascular changes, we have Bioneting sign, which is sharp angulation of the blood vessels at the disc margin due to nerve fiber layer thinning. A bearing of circumlinear vessels can also be seen, as well as overpassing of vessels. Laminar dot sign is also seen, which is fenestrations of the lamina cribrosa are seen due to thinning of the nerve fiber layer. Also, neuroretinal rim notching can be seen. We have to be very careful about the differential diagnosis, as we can rule out optic disc glaucoma. Their morning glory disc can also be seen. Most challenging is myopic disc. Hence, we have to, in these cases of myopic disc, we have to see for intraocular pressure as well as progression. We have to successively see the progression of the disease, and family history is important. Also, optic disc pit should be ruled out, and tilted disc, and most importantly, a normal optic disc. Thank you.
Okay. Very good presentation.
Thank you, sir.
Can you tell me, based on the optic disc, how can you differentiate?
Sir, just a minute. Sir, just a minute. Just a small announcement to make. Before we go to this questions for 1 minute, all the presenters kindly follow the TOT Central 4 group. I am mentioning the name of the next candidate to speak well in advance. So gather yourself well, be ready with your screen share so that we don't lose time and we have a very smooth functioning. So please see the TOT group and mark a thumbs up the moment you see your name so that you can start preparing next. So I think 1 minute question we can start. Yes, sir. Go ahead.
So Sarbik, can you differentiate whether it's a neurological damage or glaucomatous damage based on the disc evaluation?
Sir, it is a little bit difficult. We can use pallor as a sign, because pallor is more commonly seen in non-glaucomatous pathologies. We can from that we can assess whether it is a neurological cause or not. And for functional, we can use visual field examination by perimetry, because if on successive visits, if the patient shows losing of visual, if there is visual field loss, then we should refer the patient for an MRI scan and refer the patient to neurology for further examination.
Okay, good.
Thank you, sir.
Okay, fine. So what we will do is we start marking Sarbik now. All judges, please start marking Sarbik. By that time, Anjali Doshi to be ready with corneal anatomy and significance. Kindly share the screen in the meanwhile.
Okay, sir. Yes, sir.
Anjali Doshi to share the screen, please.
Yes, sir. एक minute.
Penke sir, the marking for Sarvik, please. Yes. So I think we are done with the marking. Are you ready, Anjali? Like we can't see your screen as of now. If you are not ready, we can go to the next presenter.
Okay.
Are you able to share the screen, Anjali?
Sorry, sir. I can't. I'm not able to share the screen. You can go
So
ahead.
Sneha
Sorry, sir.
Kapgate.
Uh,
Sneha, no, I can see. We can see some screen coming up. Is it your screen or Sneha Kapgate can come? Sneha Kapgate. Can we see Sneha's screen, please?
Sir,
Okay, the corneal anatomy has come. So I think Anjali,
okay.
your time will start now. We can see your screen. You can start.
Okay, sir. Good afternoon, everyone. I am Dr. Anjali Joshi from Grand Government Medical College and Sir JJ Group of Hospital, Mumbai. Today I will share the presentation on corneal anatomy and clinical significance. The word cornea come from kerato means shield, and it's a transparent and avascular structure. Then optical property of cornea. The surface area of cornea is 1.3 centimeters square, and refractive index of cornea is 1.376. Refractive power is 45 diopter. Anterior surface and posterior surface is 48 diopter and 5.8 diopter respectively. Thickness of cornea is zero point 0.5 to 0.6 micron at center and 1 to 1.2 at periphery. Then layers of cornea from outer to innermost layer. It starts from epithelial layer, then Bowman's membrane, stroma, Duas membrane, Descemet membrane, and endothelium. Then difference between the central cornea and peripheral cornea. In central cornea is more stiffer as compared to peripheral cornea. Then in central cornea, it's well organized stroma, and peripherally less organized stroma is present. Central cornea is avascular, and peripheral cornea gets supply from periphery. Then in central cornea, like the Lagrange cells are less in number, while in periphery it's more in number. Then nerve supply of cornea, it gets from the ophthalmic division of trigeminal nerve. Then it's give branches to nasociliary nerve. Then it's to long ciliary nerve and short ciliary nerve. Then it's give plexus, pericorneal plexus, and it divided into intraepithelial plexus, subepithelial plexus, and stromal plexus. Then the clinical significance, the corneal degeneration. The degeneration is mainly occurs due to, it mainly occurs due to age and some pathological reasons. Then age-related, first image show the arcus senilis. It is caused due to the lipid deposition at periphery. Then Vogt's while limber girdle. And third image shows the Hassel-Henle bodies. Uh, then the pathological corneal degeneration, the lipoid keratopathy. Causes due to the lipid deposition. Then calcific degeneration. It shows the band-shaped keratopathy. Then Chalmers nodular degeneration. The third image shows the Chalmers nodular degeneration. Then corneal dystrophy. Corneal dystrophy, it is the inherited disorder in which cells have some inborn defect due to which pathological changes may occur with passage of time lead to development of corneal hairs. Then there are types of corneal dystrophy: epithelial and subepithelial dystrophies, Bowman's layer dystrophies, stromal dystrophies, and Descemet's membrane and endothelial dystrophies. I have shown the one picture that is lattice corneal dystrophy. It is the stromal dystrophy. Then keratoconus. Keratoconus, it is the non-inflammatory bilateral ectatic cornea at its axial part. And the one image shows, the second one image shows the Monson signs. When we ask the patient to see downward, then there is bulging of the lower lid. Then keratoglobus. Keratoglobus, it is a hereditary and familial bilateral congenital disorder, leads to thinning and protrusion of cornea. Then corneal opacity. Corneal opacity leads to the loss of transparency of cornea. There are types of corneal opacity: nebular, macular, leukomatous, and adherent leukoma. Thank you.
Hello.
Judges can ask questions now for the next 1 minute.
Yeah. What is the role of stem cells? Dr. Anjali? Am I audible?
Anjali, I think the question is clear. What is the role of stem cells? Sir wants to know. Kindly answer the question, please.
Sir, it is pluripotent.
Okay.
Hello.
Yeah. Okay. Any other role? Hello.
Yes, Neha, I think last few seconds are remaining. Would you add anything to pluripotent? Otherwise, we go to the next presentation.
How Panus forms? I will give you a clue. How Panus forms? How pterygium forms?
Sorry, it's
Okay.
the pterygium. It is caused due to the conjunctival degeneration.
Yeah.
Oh,
How Panus
okay.
forms? Is there any role of limbal stem cells? Okay. Okay.
Fine. So I think judges can please mark in the TOT central for judges group. Anjali Joshi on corneal anatomy and its significance. In the meanwhile, Sneha Kapgate can be ready with her presentation on vitreous substitutes.
Yes,
So Sneha Kapgate, please load your presentation. Yeah, your presentation is seen now. Judges, please mark. Yeah, so we got all the 3 marks for Anjali Joshi. So Sneha Kapgate, your time starts now.
Good afternoon, everyone. Happy Dependence Day to all. I am Dr. Sneha Kapgate from Government GAN Medical College and Sir JJ Group of Hospitals, Mumbai, presenting seminar on vitreous substitutes. Let's first see the anatomy of the vitreous cavity. It is 4 ml in volume, occupies major part of the globe. Vitreous is a inert transparent jelly-like structure mainly made up of hyaluronic acid and collagen 3. It is developed from the neuroectodermal cells from the optic curve, and vitreous is strongly attached to the ora serrata, disc, fovea, and posterior part of the lens. Next is what are the vitreous substitutes? The substances which acts as a replacement for the vitreous in the eyeball. It is used for the tamponading effects in vitreoretinal surgeries. Ideal vitreous substitute should be inert, optically clear, and have high surface tension, and it should not lead to rise in intraocular pressure. Indications for the vitreous substitutes, it includes retinal surgeries, which includes the giant retinal tear, posterior breaks, restoration of volume after the subretinal fluid drainage surgeries. Second one is the vitreous surgeries, and third one is the post-cataract surgery if vitreous loss is greater than 2 ml. What are the types of vitreous substitutes? It includes intraocular gases, which includes expansible and non-expansible types. Expansible includes the sulfur hexafluoride, perfluoromethane, perfluoropropane. Non-expansible gases includes air, helium, nitrogen, and oxygen. Second type is silicone oil. Third type is perfluorocarbon liquids, and fourth type is physiological fluids, which includes the ringer lactate. Then most commonly used vitreous substitutes are silicone oil and intraocular gases. The differences between shown are here. In silicone oil, immediate ability to see is there. Patient can travel by air after the surgeries. Hypotony is less common in silicone oil. Alteration of refractive power is there. And eyes are more stable and revision surgeries are easier in the silicone oil. While in intraocular gases, patient can't see till 4 to 6 weeks. Should be the necessity of positioning. Patient have to avoid the air travel. Hypotony is more common in gases. Alteration of the refractive power is not there in the gases, and recurrence tends to be total and severe. Post-operative care, prone position up to 4 weeks, we have to ask for the patient. Prophylactic use of timolol and tablet Dimox. Special care with the nitrous oxide, ATIS is more expansible gas. We have to avoid trauma to the eye and regular IOP checkup. Complications, which includes the silicone oil. Most common complications is the emulsification of oil. 62% of cataract changes will be there. There may be the pupillary block glaucoma and band-shaped keratopathy. Complications of intraocular gases may occur during the injection, contact of bubble,
to the posterior part of the lens, which leads to the high intraocular pressure, lens opacity, and bullous keratopathies. The contraindications, it includes for silicone oil, it includes the severe uncontrollable glaucoma, breaks in the inferior cloak arch, while for the gases, as the air travel, as the atmospheric pressure decreases, expansion of the gases increases. Newer advancement, it includes the magnetic fluid, which have the magnetic alloys in the silicone oil with the magnetic scleral bands. Second is the polymeric vitreous substitutes, and third one is the foldable capsular vitreous body with the polyvinyl alcohol hydrogel. Thank you.
Okay. So thank you for the presentation, and I think judges can ask a question for the next 1 minute.
Have you heard of Densiron? Dr.
Just a minute, sir.
Sneha?
In the meanwhile, Dr. Shilpi Bhattacharya, you can share your screen. By that time, sir can ask the questions. Yeah.
Okay.
Yeah. Yes.
Hello, Dr.
Yes.
Hello,
Sneha?
yes, sir. Yes, sir.
Have you heard of a vitreous substitute called as Densiron and how it differs
No.
from silicone oil?
Sorry, I
No,
cannot
sir.
share my screen.
You are not able to share your screen?
No, you have to make the host.
Yeah, yeah.
While the other
techni-
participant is
previous
sharing
one
the
needs
screen,
to
she'll have to stop
You
instead.
Yeah, stop sharing your screen, Sneha. Stop sharing your
Yes,
screen.
sir.
Yeah, stop sharing. Yeah, stop sharing your screen. Stop. Yeah. Okay. So I think you can share now. By the time you can answer the questions, please. Sneha,
Yes,
what is
sir.
Densiron? Please answer. Yes, Sneha, do you know what is
Okay.
Densiron?
No, sir.
Okay, no problem. No
Okay.
problem. So the next, so doctors, judges, you can mark on our group. There is a TOT judges group in the meanwhile for the next 30 seconds, so that we can proceed with the next presentation of Shilpi Bhattacharya. It's already on the screen. Okay, so we have all the 3 marks with us. Shilpi ready?
Yes, sir.
Dies in ophthalmology. Shilpi Bhattacharya. Your time starts now.
Good afternoon, all. I'm Dr. Shilpi Bhattacharya, and today my topic of discussion is dyes in ophthalmology. Why do we need to study dye in our eye? As a clinician, it helps to diagnose and detect various ocular pathologies and as a visual tool in delineating important structures in ocular surgeries. And it forms an important part of academics for students in viva and theory exam questions. Aim of this lecture is to enumerate the various dyes used in the field of ophthalmology, their properties, clinical and surgical applications, and their contraindications and side effects. Which dyes do we know? Let's list them out. Fluorescein, rose bengal, lissamine green, trypan blue, brilliant blue, indocyanine green, and triamcinolone acetonide. Talking about the most commonly used stain, which is the fluorescein stain, is available in 2 forms: strips impregnated with dye and intravenous preparation for fundus fluorescein angiography. Fluorescein has multiple uses in conjunctiva, cornea, glaucoma, nasolacrimal duct, and retina and choroid. In the conjunctiva, it is used to calculate the time taken for the first dry spot to appear in tear breakup time and for tear meniscus height estimation, both required for the diagnosis of dry eye disease. In the cornea, it helps us stain corneal abrasion, epithelial defects in foreign bodies, to study the different patterns of viral keratitis, and for rigid gas-permeable contact lens fitting. In glaucoma, it helps us measure the intraocular pressure by Goldmann applanation tonometry by adjusting the Myers. We also perform Siegel's test, where we see a stream of fluorescein diluted with aqueous, where we suspect food leak and bleb leak post-trabeculectomy surgery. It also helps us perform nasolacrimal duct patency test using the Jones dye test. Fluorescein angiography helps us detect capillary non-perfusion area, sites of leakage, pooling, and staining in retinal vascular disorders. Intravenous fluorescein is to be used with caution as it causes anaphylaxis and is contraindicated in renal disorders and pregnancy. Next up is the rose bengal stain, which is used to stain the dead and devitalized cells, including mucous strands and ocular surface. It is used in conjunctival staining for the diagnosis of dry eye disease, corneal staining for herpetic epithelial dendrites (SPKs), and ocular surface squamous neoplasia. It causes ocular stinging and discomfort and is less preferred. Moving on, we have the lissamine green, which is used to stain the bulbar conjunctiva in the diagnosis of dry eye disease and is preferred over rose bengal stain. Next up is the most commonly used stain, which is the trypan blue dye, which is used to stain the anterior lens capsule to perform a capsular excess, hence facilitating an important step in any cataract surgery, especially phacoemulsification. It stains the Descemet's membrane and aids in its stripping, in Descemet's stripping endothelial keratoplasty, and also stains the epiretinal membrane in vitrectomy procedures. Next up is brilliant blue, which is used to stain the internal limiting membrane by its technique of negative staining, where it stains the epiretinal membrane but not the internal stains the internal limiting membrane but not the epiretinal membrane, hence causing easier peeling of the epiretinal membrane while performing vitreoretinal surgeries. Next up is the indocyanine green, which is also used to stain the internal limiting membrane in vitreoretinal surgeries and is used as a diagnostic tool in indocyanine green angiography, which is superior to fluorescein angiography in detecting choroidal lesions, as it is strongly bound to plasma protein and diffuses less out of choriocapillaries and has less side effects with its intravenous use. Lastly, I'd also like to add about triamcinolone acetonide, which is, though being a steroid, is used to stain the vitreous in posterior capsular tear in cataract surgery and in routine vitrectomy procedures. I hope this lecture has helped you understand the name of the dyes and the clinical applications. And I would like to conclude by saying eyes are needed to see colors in the outside world, but colors are needed to see the inside of an eye. Thank you to the organizing community.
Okay. So there was a nice presentation. So judges, you can take over for 1 minute for questions.
Hello.
Yes, sir.
What are the therapeutic uses of fluorescein?
Just a second. By the time you answer, you can just unshare your screen, please, so that the next person can share. Dr. Bhakti Gade can share the screen in the meanwhile, till we get ready for the next presentation. Now you can answer. Sir, please come with the question again, and Shilpi will answer it.
What are the therapeutic uses of fluorescein?
So the therapeutic uses are in FFA, we can diagnose the retinal vascular disorders and so
anything to add? Last few seconds, Shilpi.
No, sir. I'm not so sure.
Okay, fine, no problem.
Thank you, sir.
So yeah, Bhakti Gade can share the screen, please.
Yes, sir. 1 second.
Yeah, Shilpi, you can unshare your screen. Is Bhakti sharing her screen?
Sir, can you see my screen?
It's a vote of thanks that I can see.
1 second, sir. I'll share again.
So in the meanwhile, please mark on our WhatsApp group. Kindly give marks for Shilpi Bhattacharya.
So can you see my screen?
Yeah, differential diagnosis of limbal mass. Yes. We can see it. So I'll tell you when your time starts. We are awaiting the last marks for Shilpi.
Yes, sir.
Dr. Painke, sir, your marks are awaited. Okay. So Shilpi Bhattacharya, your marks are available. So now I think your time starts. Bhakti, your time starts now.
Good afternoon, everyone. I'm Dr. Bhakti Gade, and I will be teaching you the differential diagnosis of limbal mass. 1 second, sir. I can't. 1 second.
Yeah. Just go to slideshow and then just.
1 second.
We have paused the time for you.
Yes, thank you, sir.
Yeah. Share the screen and scroll it.
Yes, sir. 1 second. I'll start again, sir.
Yeah, please.
Okay. Good afternoon, everyone. I'm Dr. Bhakti Gade, and I will be teaching you the differential diagnosis of limbal mass. So the importance of this topic is twofold. As clinicians, we need to know how to approach a mass present on limbus. And as students, it forms an important topic from exam point of view. 1 second, sir. I'm facing some technical difficulties. 1 second, sir.
You have to sort it out fast. We have given adequate time for you beforehand to try.
Sorry,
10
sir.
minutes. You can keep the slide sorter view on, and then you can play the slide, no problem. But we wouldn't be able to give you much more time. Huh?
Okay, sir.
Yeah, start.
The importance of this topic is twofold. As clinicians, we need to know how to approach a mass present on limbus. And as students, it's an important topic from exam point of view. The aim of this lecture would be to enumerate the etiology of limbal mass, the morphology of limbal mass, and its subsequent management. So the limbus is defined as a circumcorneal transition zone between the cornea and sclera. The etiology could be congenital, allergic, inflammatory, degenerative, vascular, neoplastic, and miscellaneous. Congenital cause includes a dermoid or a nevus. Inflammatory causes include episcleritis and scleritis. Allergic causes include vernal keratoconjunctivitis, ophthalmia nodosa, and flicton. Degenerative causes include spingancula and cystic pterygium. Vascular cause would be a hemangioma, and a neoplastic cause would be ocular surface squamous neoplasia or melanoma. Miscellaneous causes include Bitot spots, retention cysts, filtering bleb, and intercalary staphyloma. Oh my God, so many masses. So how do we approach this mass present on limbus? So we start with the clinical history, where we ask the onset of the mass, the duration, the progression of the mass, and associated symptoms. Then we proceed with examination, where we take the patient's visual acuity, followed by slit lamp examination. On slit lamp, we look for the size, the shape, the extent and location, margin, color, surface characteristics, and staining with dye if possible. So if a mass is well-defined, localized, present since birth with variable surface characteristics, it's probably a limbal dermoid. Whereas if it's present since childhood and is pigmented, it's probably a nevus. If it's well-defined with localized congestion in a patient with history of tuberculosis, it's probably a flicton. Whereas if it's well-defined without localized congestion, it's a non-inflamed pingancula. Multiple well-defined masses present in a patient complaining of watering and itching is bound to be Horner-Tranta spots present in vernal keratoconjunctivitis. Whereas if the mass is well-defined with localized congestion, which blanches on a drop of phenylephrine, it's bound to be episcleritis. If the congestion is diffuse and the patient has some underlying autoimmune disorders, it's going to be scleritis. If there's a whiter cystic mass present in a patient with history of glaucoma and ocular surgery, it could be a filtering bleb. Whereas if the mass is wing-shaped and encroaching the cornea, it could be a cystic pterygium. An ill-defined silvery foamy mass present in patients with multiple nutritional deficiencies point towards a Bitot spot, which is present in vitamin A deficiency. An ill-defined mass with the presence of a feeder vessel point towards ocular surface squamous neoplasia. An ill-defined progressive and pigmented mass points towards a melanoma. We proceed with ocular investigations where we do anterior segment optical coherence tomography and ultrasound biomicroscopy in patients where we're planning a surgical excision to look for the depth and extent of the mass. Then we proceed with systemic investigations where we do blood investigations like complete blood count, ESR, and CRP levels, followed by chest X-ray and Mondu test in patients with scleritis or flicton to confirm tuberculosis. A CT scan of brain and orbit is done for limbal dermoids. The treatment of every mass differs on the basis of etiology and symptomatology of the patient. It could be medical treatment in the form of topical lubricants and steroids in some, whereas in some it could be a surgical excision with ocular surface reconstruction. In conclusion, each mass has a unique feature. The history and investigations help in coming to a probable diagnosis, and the management differs on the basis of etiology. Thank you so much. I would like to thank the organizing committee for giving me this opportunity.
Okay, judges, you can go ahead with questioning her for the next 1 minute, please.
It was a very good presentation. Can you tell me how will you approach a case of diffuse mass near the limbus?
Okay, sir. So a diffuse mass near the limbus, I will ask the history of the mass. Since when has it started? Is it acute? Is it progressive? If it's wing-shaped, I will think of a pterygium. If the patient, I can see that the patient is malnourished, he has multiple nutritional deficiencies, it's silvery, foamy white, then I'll think of a Bitot spot. If it's ill-defined and it's pigmented, then I'll think of a nevus or a melanoma if it's progressive. Apart from that, if it's ill-defined, if it's gelatinous, if it has various surface characteristics, if there's a presence of a feeder vessel that I can see, I'll think of a ocular surface neoplasia.
Okay, anything else the judges want to ask?
Yeah, that's it.
Okay, thank you, sir.
Okay, very good, very good. So up next, we have Riya Singhal. She's put up her PPT. In the meanwhile, judges in the next 30 seconds can put up marks for Bhakti for her presentation. Bhakti Gade, DD of limbal mass. We almost have the marks with us. Dr. Penke is yet to give the marks. Yes, so we have all the marks with us, and I think Ria has already shared a screen. I would request the next presenter to be ready with screen share by the time Ria finishes. So Ria, your 4 minutes will start now. You can start presenting.
Yes, sir. Yes, sir. Good afternoon. This is Dr. Ria Singhal from Grand Government Medical College at JJ Group of Hospital. I will present refraction in children mentored by Dr. Shalmali ma'am. Eyes are different. Anterior posterior diameter of the eyeball at birth is 16.5 mm, which attains adult size by the age of 7 to 8 years. Newborn are born with hypermetropia in their eye and become emetropic by the age of 7 to 8 years. This process is known as emetropization. Competition is very strong in children, which reduces steadily.
I cannot see the screen. Anybody can see the screen? Can anybody see the screen? Okay, okay. Continue, please.
Eyes at birth are different. There is problem with the pediatric refraction. That's why it is different from the adult refraction. Subjective refraction is difficult to perform in children. That's why we have to completely on the objective included on the basis of retinoscopy. Also, accommodation varies in children. That's why we have to base readings on retinoscopy as well. Change in refractive status in infants and toddlers is very fast, so we have to do constant monitoring for them. What is metropization? It is a process in which refractive power of the uses proportionate to increase in the axial length of the eye. If we prescribe full prescription during the process of emetropization, it can have to high refractive error. So it is still debatable whether we should give full refraction to the children or not. But if the error is associated with the isoradiation, we have full prescription. What is retinoscopy? Retinoscopy is an objective method of finding out error of refraction by the method of neutralization. It is based on the principle that light is reflected from the retinoscope into the eye of the and on the basis of the movement of the light of the eye is concluded. It is a crude procedure, and basically there are two types of retinoscope: mirror and self-illuminated. Mirror retinoscope is simple, can be simple plain mirror or in combination with the concave mirror, which is Priestley Smith, while the self-illuminated could be streak. Streak is more popular and is sensitive. How do we perform retinoscopy? In this, child is made to sit in the and the retina is moved in horizontal and the vertical direction. If the light reflex moves along with the retinoscope, that means child can be emetropic or myopic power less than -1. If it moves against, child is myopic with power more than -1, and if there is no movement, child is myopic with power -1 only. We also refractive status on the basis of the characteristic of red reflex. If red reflex is faint and it moves rapidly with the movement, there is low degree of error, while if it is dark and moves with high degree. Also, if there is swing and swirling of this, it has we also, as child has accommodation, we also the most common use cycloplegics are atropine, cyclopentolate, and the homotropine. So we judge the retinoscopic finding, we have the distance that it performed, and we also deduct the cycloplegic use, which is D for atropine and 0.5D for homotropine and the cyclopentolate. If horizontal and vertical media have equal power, it means spherical slide. If they are different and only cylindrical power is given, it is simple astigmatism, and if it in combination with astigmatism. Static and dynamic retinoscopy can be differentiated on the basis of accommodation, in which retinoscopy has accommodation and dynamic retinoscopy we judge the accommodation. So in conclusion, parents should be educated to understand the importance of refractive error correction and occlusion therapy for the amblyopia. Follow-up is must and compliance is important. A proper corrective correction can lead to prevent of and also lead for and also have management for the same. Thank you.
Hello.
Hello.
What are the side effects of atropine? Good afternoon.
Yeah, just
what
a
are
minute.
The side effects
so
of
yeah,
atropine?
Yeah, please answer the question. Are you listening?
Yes, sir.
Yeah, please answer the question. What's
So
the Yeah, side effects of atropine.
atropine can lead to blurred vision, blood and decreased vision. Pupil, it would be dilated for a longer time, like it is a strong page. It might be
These
for
systemic
4
side
days.
effects, which you have to warn to parents. Any
So
systemic side effects which you need to warn to.
So it can lead to decrease in urine production and decrease in frequency of urination. Hello.
Okay. And
It can
few
lead
more.
to respiratory failure.
I can't hear.
Yeah, can you please repeat loudly?
Yes,
Last two, three that you.
Atropine is an antimuscarinic drug, so it can lead to dilated pupil, warm and dry skin, decreased urine production.
Systemic problems. One is retention of urine. Other anything you want to add? Systemic problems.
Yes, sir.
One more important, which is quite common. Which is very common. Okay.
Okay, chalo. So in the next 30 seconds, as the judges mark, Shikha Kumari can be ready with her newer IOL's presentation. Judges can mark on our internal WhatsApp group. So we collate the marks for Ria single refraction in children. Yeah, Shikha is already sharing her presentation. We can see it. So as the marking gets finished, we would be ready with timer for Shikha. 1 mark is available. Waiting for Gadre and Penke, sir. Yeah, just a minute, Shikha. We'll start in 5 minutes.
Good afternoon, sir.
Yeah, just a minute, please. Yes, so we have all the 3 marks that are available with us. So I think Shikha can start with her presentation on new intraocular lenses. Shikha, go ahead, please. Your timer starts now.
Good afternoon, sir. I am Dr. Shikha Kumari from Grand Government Medical College and Sir JJ Group of Hospitals. My topic for today is newer intraocular lens. So what is intraocular lens? It is an artificial lens implanted in eye, replaces the crystalline lens to correct the optical power of eye, called cataract surgery or refractive surgery. So what is the history? First intraocular lens was implanted by Harold Ridley, sir, on Feb 1950. What is the need of continuous interventions in this field? Old paradigm, patient want to see better than they did with the cataract. And new is patient want to see better than they did before they developed cataract. So that was a joke. Actually, the patient expects freedom from the spectacle after cataract surgery. That is why the hunt for IOL, the ideal IOL is still going on. So the generation of IOL, 8th generation still now, rigid posterior chamber belongs to 5th generation, foldable IOL belongs to 6th, multifocal IOL belongs to 7th, and phakic refractive IOL and accommodative IOL belongs to 8th generation. So we will talk on based on the optical correction. There are different types of IOLs, monofocal IOL, multifocal IOL, extended depth of focus IOL, and accommodative IOLs. So the monofocal IOL offers spherical correction for a single distance, and many ophthalmologists first choice because of their superior image clarity and minimal visual aberration. In addition, they are ideal for patients with pre-existing ocular comorbidities. So the advances are Technics eye-hands. It is also called monofocal plus as it additionally provides functional intermediate vision and excellent distant visual acuity. Second is NVISTA. NVISTA provides additional depth of focus. This one is eye-hands and NVISTA. Light adjustable lens. Adjustable lens is silicon 3-piece monofocal IOL that filled with macromers, a photosensitive material that changes the lens shape and power in response to ultraviolet light. Multifocal IOL. Multifocal IOL are IOL with 2 or more focal points. Mechanism used is refractive, diffractive, and combined. Multifocal IOL utilize diffractive optics to create 3 distinct focal points. As a result, they allow for the greatest range of near, intermediate, and distant vision. In past, we have some problem with the multifocal IOL, that is dysphotopsias, halos, and some discrete optical zones were present, not a smooth transition between the focal lengths. Refractive type are
two-zone, and annulus type. Example for multifocal lens are panoptics, that is the latest multifocal option, and techniques, that is a hybrid lens, part trifocal and part EDOF. Extended depth of focus, IOL. EDOF lenses extend the range of focus and augment intermediate and near vision via the creation of a single elongated focal point rather than several foci, as in multifocal lenses technology. Accommodative IOLs. It interacts with ciliary muscle and zonulated zonules using hinges at both ends to latch on and move forward and backward inside the eye. Provide excellent vision at all distances, no loss of contrast sensitivity, no halos, and so there is advantage over multifocal lenses. Toric IOLs. Toric IOL are referred to astigmatism correcting IOLs at the time of cataract surgery to decrease post-operative astigmatism. Toric IOL are available as monofocal and multifocal. Most common drawback of these lenses are post-operative rotation of the lens. Some examples are Acrisoft, Hoya, Isert, Toric, Star Toric IOL. Future IOLs. Future IOLs are telescopic IOL and electronic IOL. Telescopic IOL can be used for ARMD. And
your time is up.
Thank you, sir.
So as we proceed to the questions, kindly unshare your screen so that Nikhil Thakare can share the screen. He is in waiting. Meanwhile, judges can ask the questions for her, please. Judges, please go ahead with the questions for newer IOLs.
Shikha, you told us about the newer IOLs. Out of these, which best IOL you will go for your grandfather? Which one is the preferred IOL you will select?
Sir, accommodative IOL, I will go for.
You will straightway go for the accommodative IOL, or you will go for the whatever his needs?
Yeah, sir, that depends on the need of the patient.
What else?
And the expectation after the surgery. And cost.
What else?
Okay, the last few seconds for you before to answer. Can you, sir, think of some other points? What sir is looking for?
So
last chance for you to answer. Next 10 seconds. Think and answer. 10 seconds.
Okay, no problem.
Okay,
Next
I
one,
think
please.
the time is up. But the time is up. In the meanwhile, as Nikhil gets ready, judges can mark her for newer IOLs on our judges group, please. Shikha Kumari for newer IOLs. So Nikhil Thakare has already shared his screen. So once I give the go ahead, Nikhil will start presenting. We are awaiting the marks from the judges.
okay, sure.
Penke sir, Dobekar sir have already given their marks. We are awaiting Girish Gadre sir. Gadre sir has also given his marks. So I think over to you, Nikhil Thakare. He'll be presenting on biometry. Nikhil, your time starts now.
Good afternoon, students. Today we are going to study about an interesting topic, biometry. So what is biometry? It is the application of mathematics to biology. When it comes to ophthalmology, it typically refers to pre-operative measurements made for IOL power calculations. Axial length and corneal curvature are the most important ocular dimensions measured. On the basis of technologies that are used, biometry devices are classified into ultrasound devices and optical devices. The ultrasound devices are applanation A-scan and immersion A-scan. Whereas on the basis of optical technologies used by the devices, optical biometry devices are further classified into partial coherence interferometry, optical low coherence reflectometry, and swept source OCT. The examples are as mentioned below. In A-scan ultrasound biometry, we measure the axial length, anterior chamber depth, and the lens thickness. Here we use a high frequency sound wave, which causes low penetration but given high accuracy, but we require separate K reading. In the image attached here, we can see an ideal A scan where 5 different spikes are seen. The first spike coming from the probe and the cornea, the second and third coming from the anterior and posterior lens surface, then is the vitreous fold, then is the retinal spike, followed by the scleral spike. On the right hand side, you can see that we have fairly constant axial length values. This is what we have to achieve. Contact A scan, though being easier, is prone to indentation areas, whereas immersion A scan, though was the standard at a time, is a time-consuming procedure, and there are issues with error in alignment of probe with the visual axis. So we came to optical biometry. The principle is being shown in this animation. As the rays of light hit various ocular structures and they are reflected back, the dimensions of these structures are measured. So what are the differences? In optical biometry, the optical axial length is measured. It is 10 times more accurate than ultrasound biometry, and it is useful in pseudophakic, phakic IOL, myopic eyes with staphyloma, short eyes children, as well as in silicon oil filled eyes. But ultrasound biometry is still useful in dense cataract, but this issue has been resolved with swept source positivations. Now, what are the tips for avoiding mistakes? During keratometry, we have to avoid prior corneal procedures. Take an average of 3 readings. Repeat if the readings are inconsistent. While measuring axial length, measure both the eyes. Repeat if the difference exceeds 0.3 mm. Proper alignment and gain setting has to be ensured. Avoid indentation and take 5 to 10 readings. And remember, avoid anisotropia. Now, we have done biometry. How to choose the power of the eye? Following factors have to be considered. What is the refractive status and presence or absence of cataract in the fellow eye? What is the lifestyle of the patient? And remember, a myopic patient would be unforgiving if he or she is made hypermetropic. These are the various formulas that are used for IOL power calculation, and depending upon the axial length, these formulas are preferred. However, Barrett Universal Tube formula is the current gold standard. These are the special conditions that we are likely to encounter. In pediatric cases, we are likely to use Hoffer-Q and Haigis formula, where we use 80% of the correction up to 2 years. In corneal ectasia, we use Hoffer-Q and Haigis formula. In aphakia, immersion or optical biometry in aphakic mode has to be used. In pseudophakia, Holiday formula is to be used. In high myopia and posterior staphyloma, Barrett Universal 2 formula can be used. In retinal detachment and corneal scar, fellow eye biometry is the standard. For microphthalmos, Hoffer-Q formula. For post-vitrectomized eyes, optical biometry. And nowadays we are encountering a flood of post-refractive surgeries. So here we can use calculation methods or regression formulas. Thanks. I hope I was able to let you know how biometry works, and I will be ready to take any questions.
Okay, thank you, Nikhil. You can stop your screen share so that Abhinav can go live. And in the meanwhile, judges can be ready with their questions for the next 1 minute for Nikhil. Start.
What A stands for A scan?
A constant scan. Amplitude
Pardon?
scan. Amplitude time scan.
Yeah, what amplitude? Whose amplitude?
So the
And what is the
ultrasound
relation of
rays,
that amplitude?
the
Correct.
ultrasound
Okay.
waves that are being used in the probe, they travel and they are reflected back. Its amplitude is being shown, and its relation with the time is shown. And on the basis of that, we calculate the axial length.
Okay. If you have a patient who is having silicon oil filled eye, what your
Okay.
IOL power calculation will be? Like what could be the mistake and how wrong it will be?
So if we go for A scan, we won't be able to get the proper retinal spike. So that would not be used. We can go for optical biometry, as I mentioned again. Also in silicon oil eyes, the silicon oil acts like a negative lens. So we have to account for that addition of the hypertrophic shift that has to be done.
Okay, thank you.
As well as-
So that comes to the conclusion of this thing. Judges can mark Nikhil Thakare for his biometry talk on our judges internal communication group. In the meanwhile, Abhinav Gogoi has already shared his treatment of neovascular glaucoma. The moment we get the marking, we'll start Abhinav's. That is our last presentation for our group. Okay, so we have got 2 marks, and Gadre sir is on his way for his marking, and Gadre sir has marked. So excellent. So we are up to the last presenter, and we have Abhinav Gogoi presenting to us on treatment of neovascular glaucoma. Abhinav, are you ready?
Yes, sir.
Just a minute. So your timer starts now.
Okay. Good afternoon, students. Today I am going to talk about treatment of neovascular glaucoma. First, you know the treatment of neovascular glaucoma. So 1 second, it is not changing. First, to know the treatment of neovascular glaucoma, we must know what is neovascular glaucoma. It is a type of secondary glaucoma in which the angle is upward by the neovascularization and there is angle closure, which leads to a sequelae of glaucomatous atrophy. These are the characteristics of the new vessels are, these are very friable as they have very absence of tight intercellular junction. We can see in the left hand side picture, there's rubeosis iridis in the iris. And in the gonioscopic image, we can see that the new vessels are invading the scleras first. Now the pathogenesis of neovascular glaucoma. It causes retinal ischemia, which leads to an imbalance between the angiogenic and anti-angiogenic factors. Angiogenic factors like vascular endothelial growth factor increases, which leads to the proliferation of epithelial cells and also causes neovascularization, which occludes the trabecular mesh and leads to a formation of a fibrovascular membrane. Now, according to the stages, we can give the treatment modality. Stages of rubeosis iridis, in which the neovascularization is present in the iris, which we can see in the image B. Stage of secondary open angle glaucoma, in which the neovascularization is in the angle, but is still not obscuring the angle. We can see another image in image B. Stage of secondary angle closure glaucoma, in which the angle is completely obscured by the fibrovascular membrane, which contracts. Here we can see an image in the F, we can see usual exoplan. Basically, the management is done by medical management, in which we can use anti-glaucoma medications like aqueous suppressants like beta blockers, alpha-2 agonists, and carbonic anhydrase inhibitors. So, pan-retinal photocoagulation can also be done, which causes a regression of the neovascularization, but cannot regress an already established fibrovascular membrane. Intraocular anti-VEGF injection can be given, which suppresses the neovascularization, but the effect only lasts for 3 to 6 weeks. It creates an opportunity for PRP laser to be done or glaucoma filtration surgeries to be done. Glaucoma filtration surgeries like trabeculectomy with adjuvant mitomycin C or an artificial filtering shunt can be done. Although preoperatively, anti-VEGF injection can be given if there's an active inflammation or neovascularization. Ciliary body ablation can be done, which is a cyclodisruptive process. There are 3 types: transscleral, endolaser, and cryotherapy, which should be done in 2 settings so as to not cause hypotony, which is a common side effect. Based on the sequelae of treatment, it can be divided into 3 types. Stage 1, which is pre-glaucoma, in which there's neovascularization in the eye. We can give a pan-retinal photocoagulation and an anti-VEGF injection. In neovascularization of the angle, if the IOP is also raised and the angle is open, we can give a PRP laser, anti-VEGF, and anti-glaucoma medication. If required, glaucoma filtration surgery can also be done. If the angle is closed, then we can give all the above stated modalities. Sequence of treatment should always be based on the history, investigation, visual acuity, and the slit lamp examination, gonioscopy, IOP measurement, and fundus examination. So basically, if the neovascularization is in the iris, first we do correction of systemic factors like CRVO and diabetes with anti-VEGF and PRP laser. If the neovascularization is in the angle with a raised IOP and the angle is open, we can do all of the above treatment modalities with an anti-glaucoma medication and if required, a glaucoma filtration surgery. If the IOP is raised but the angle is closed, we can do everything else, all the above treatment modalities with a cyclophotocoagulation. This is the basic management of a neovascular glaucoma in which the IOP spikes.
Your time is up. Your time is up.
Thank you.
Yeah. Thank you for presentation. And in the next 1 minute, the examiner will ask you questions. Sirs, can you go ahead and ask Abhinav questions on neovascular glaucoma, please?
Abhinav, can you tell me few differential diagnoses of the neovascular glaucoma?
Yes, sir.
The presentation is like a neovascular glaucoma, but what could be else?
Yes, sir. Few differential diagnoses are diabetic retinopathy, pseudo exfoliative glaucoma,
especially in pediatric population?
in pediatric population. No, sir, I don't know.
If you hello,
Yes, sir.
Yes, sir. Go ahead,
am I
please.
audible?
Abhinav, listen to the question. Yes, you are audible, sir. Go ahead.
Yeah,
Yeah,
you can stop
because
sharing
in
screen.
neovascular glaucoma,
Yes,
pupil
sir.
is not dilating, so you cannot do
Yes.
PRP. So
Yes, sir.
what could be the another option?
So to control the active inflammation in neovascularization, we can do an anti-VEGF injection, sir.
Okay, but
It is
anti-VEGF
still
injection will be for the temporarily. That will
Yes.
work temporarily.
Yes,
You need to ablate retina for long time. You have to
Yes.
make it anoxic, so that
Yes.
oxygen requirement has to be reduced. So PRP's
Yes.
role is to reduce oxygen requirement. What
Yes,
else
sir.
you
We
can do
can.
other than PRP, because pupil is not dilated? Yeah.
Yes, sir. We can, by using an indirect ophthalmoscope, we can go to the operating theater and put iris hook. If the eye is quiet only, we can put iris hook, and we can do a PRP laser only if the eye is quiet. If there is no active inflammation after giving an antibiotic.
Have you heard of cryotherapy?
Yes, sir.
Yeah. Okay.
Okay, thank you. With that, we come to the end of the excellent session by all presenters.